To the latest edition of the Hillingdon Hospital's NHS Foundation Trust podcast. I am Jonathan Lowe from the communications team, and I'm delighted to say I'm joined by a very special guest in Alex King. Alex is head of clinical health psychology here at the Trust and is here to talk about the journey that he's been on to get to where he is today, the role of clinical health psychologists, a bit more about his department and plenty more as will be revealed in the next 20 minutes or so. So first of all, welcome to the podcast. Alex, can you just start us off by introducing yourself and telling us a bit about your role, please?
Terrific. Well, thank you for the invite, Jonathan. That's sort of very kind. I haven't been at Hillingdon that long. I joined as head of health psychology in August last year, so I'm just coming up to a year shortly. Hopefully a lot of people will remember the outgoing previous head of psychology, Simon DuPont. He'd been here for, I think, a good 20 years. He's very established in the hospital, actually kind of created a structure here that, really sort of defined good practice in lots of ways for a lot of other units. Across the sector, across London, and so on. So I had the pleasure of being here a while back. I had worked here in 2006. When I came back, and I was sort of, you come into your new department, you're thinking, let me have a look around. So open some drawers, looked at some inboxes. Lo and behold, what do I find? I find some sort of letters that I wrote still in an out tray. So I'm like, right, you guys, it's 2006. We haven't sent this out yet. I'm just joking. It was some copies of some sort of reference letters and things like that. But, bless them, they kept them. So there I am back again, 2023. As head of psychology, I oversee about sort of 25 people who do various things across clinical health psychology sort of specialties, and probably sort of expand a little bit more on that. We also work on the pain management program for Hillingdon Hospital. And we also, effectively, we are a sort of a joint kind of enterprise with the community and mental health partners, CNWL. So we're kind of Hillingdon Hospital and CNWL sort of joint project, which is very nice. You do have a little bit more, a few extra bosses to contend with, but overall it's kind of how it should be, because fundamentally clinical health psychology is about that attempt at bringing in the psychological expertise to improve the healthcare, improve the medical outcomes of people that the hospital treats. And medical, I use that in most wide sense, just to underline the health, I suppose. Particularly in the widest possible sense. So surgeons are included too. That's our kind of mission overall. What I'm trying to do is, having spent a few months getting to meet people and finding all little bits of archives and all little bits of letter landing around. Getting a good feel of the people we've got, sort of connecting with the kind of clinical leads, the divisional leads, the specialty leads, the various kind of clinics and departments that sort of refer to us, just making the connection. So it's particularly welcome to be here, and hopefully some people who hear this might say, oh yes, I should really drop Alex a line. So that would be delightful. What else did you ask me? You asked me, okay, what was I doing until then, right? So I've done about 16 years of cancer psychology before this. So initially at Guy's St Thomas, and then last 10 years at Imperial down the road. Hammersmith and Mary's Charing Cross, so as consultant psychologist, so lead psychologist for cancer over there, and kind of the opportunity came here to sort of Hillingdon to move here, and which is fantastic because I live about 5 minutes up the road, which is really nice. And that was Simon. That was Simon's doing. He said, "Oh, Hillingdon's very nice. Why don't you stay here?" So I did, and so I've been, traipsing downtown to St Mary's and so on for a while. And I thought, oh, look, what a nice opportunity to grab my bike and roll down to Hillingdon Hospital. So it's very, very nice to be able to be here. And it feels particularly warm and nice to be, living somewhere and sort of being part of the sort of hospital that is sort of so connected, so established. In fact, probably a little bit too connected. It has to come down, I understand, right? It's getting rid of it. We're getting a new one, which is just my luck, really, because, as everybody knows, the estate situation at Imperial is terrible. So we come here and we're like, okay, great. And it's like, oh no, 5 more years of, so there we go.
So I wanted to ask you was, I mean, we touched on it just before we started recording the podcast, in terms of a clinical health psychologist then. I mean, I guess my first question is how does one become one?
Yes.
Sort of the training involved, and maybe just give a couple of examples of your day-to-day work if you can, because obviously I imagine it's quite varied and very different, but if you can sort of just give us a couple of examples.
Terrific. Yes, I think it's a good one to start with a kind of career pathway because we are in a kind of position, often very much kind of people in the hospital who work in the hospital who aspire towards a career. Perhaps they're kind of not in a sort of professional track like kind of nursing or kind of medicine or whatever, but are kind of perhaps working and they're thinking, oh, could psychology be something that I pick up? So it's nice to be able to say, look, here's just usually sort of how it goes is you've got your undergraduate psychology degree, right? And psychology is one of the most popular undergraduate degrees, very much kind of in the top there across the UK. So there's an awful lot. But actually, then the step to applied psychology is a different matter, right? So there's a number of applied psychologies, like let's say educational, right? So psychologists who train to apply their skills and knowledge in the domain of schools, education, and learning, and evaluation of those factors, sports and exercise, and so on and so forth. So clinical psychology is probably quite small amongst all these. Usually after a degree, there'd be a period of 2 to 4 years. It might involve a postgrad degree, like a master's. It might involve 2 to 3 years, usually, of a variety of roles at sort of perhaps assistant level. There might be NHS, there might be research roles, so research assistants. Occasionally, people do PhDs in that time. But the idea in that time is to if for people who want to pursue a career in clinical, is to sort of build up an understanding of the concepts, the values, the working life, and I suppose the kind of the structures in which a clinical psychologist works. Because then they have to apply to, there's a sort of national application process to the NHS-funded clinical doctorates that sit in a variety of universities. with their clinical placements being regional. So it's a bit similar, a bit different than medical training. So here we sit in the North Thames region. There's a number of university courses. Each university will sort of select. The selection rate is about 5% of people who apply get onto the clinical doctorate. It's very popular because it's an NHS-funded program. It's a doctoral program. So it's pretty selective. People would have already done a lot of work, would have had really good results, have done a lot of work, had been sort of fortunate, perhaps to some degree, to find the right opportunities, placements, and so on, to develop that portfolio. It gets them an interview that gets them onto the regional training course. And then they spend 3 years doing a variety of clinical placements, a variety of subspecialty areas, doing their kind of teaching and an education component and doing a research component. We host about 3 or 4 or 5 of these trainees at any one time from places like Royal Holloway, UCL, UEL, the other side because it's North Thames, and so on. And I think our friends at Brunel Psychology aspire to building a course as well, so that'll be a pleasure. So after that, effectively, that's at the completion of your doctoral. You do various silly things in your graduation, but let's just overlook those. We then start to work in, fully as a kind of qualified psychologist. Although, in the previous X years, usually people also work in NHS roles. But after that, you're a qualified psychologist, a clinical psychologist. The experiences you would have spanned things like kind of mental health, adult mental health, right? Older adults, child mental health. We're a subset of that. We're a sort of subspecialty called clinical health psychology or health psychology, just to make it a little bit easier. There are some differences to health psychology proper as an academic discipline. But when clinical psychologists work in a health context, like an acute hospital, like Hillingdon, we usually call that clinical health psychology, or just health psychology to be a bit more impressionistic, I suppose, than precise, but just trying to, give our colleagues who don't know all the various differences a ballpark idea. So, at that point, people might come straight into clinical health psychology after qualification, into any of the specialties. And usually you work into a specialty. You don't, there are differences in terms of, AHPs, for instance. They rotate in early career. Psychologists are not like that. There's no sort of rotational element after qualification. Equally, it's sort of similar to the medical training in some parts, but not entirely. For us as well, sort of, consultant sort of clinical leads don't overlap with qualification. At qualification, you're not consultant. That comes at some point later when you're overseeing a clinical specialty, when you're overseeing a department, when you're overseeing a more substantial sort of specialty area. So there are sort of similarities and differences in that kind of career path. It's a pretty, it's a pretty substantial workforce, but tiny compared to, your sort of your nurses, your doctors, your HPs, your healthcare assistants, and so on and so forth. So you go quite far down the list before you hit psychologists in your, in your budget statement. So that's the kind of career trajectory. And you're also asking a little bit about, sort of an example, right?
Yes, kind of, yeah, sort of some of the work that you do. So I imagine there's not too much awareness of what, I mean, people I imagine have heard of you, but not necessarily know too much about what you do.
Yes. So, one of the things a psychologist do is they ask a lot of questions. So, Jonathan, what do you think we do?
Well,
And
this,
I'm
like
putting
you
you on
said,
the spot there,
that's
right?
certainly a very good question. Yes. I mean,
What do you think?
for me, I would think you deal with patients who um, are experiencing problems, say problems, but sort of issues with their mental health, um, and you try and dig a bit deeper and trying to gain a better understanding of what is making them carry out certain actions, or what is making them say certain things, and how that is impacting their everyday life. And you're trying to gain a better understanding of their situation and try and kind of knit everything together and kind of work out why things are happening, why they
Wonderful.
are.
Wonderful.
Is that
Well,
in any way accurate at all?
yes, because what you really pick out there is the kind of element of just very compassionate exploration, right? The bit where you're kind of joining somebody and trying to really understand, what's on their mind, right? What's in their world, their mental world. So that is really, really good. Um, and the bit that I would add to that is that I think that's very common, that sort of people think inevitably, yeah, sort of psychologists, clinical psychologists are about the mental health of kind of people. And that's true because it is really about the mind, right? But also, in some other way, we have this kind of system, right, where we have the kind of health, hospitals and sort of mental health, and they're kind of, and there's people in between. And I think it doesn't quite emphasize the bit that I was pinging on sort of before, which is really the reason we're doing this, right? The reason we're doing this, the reason we're doing that kind of compassionate exploration and that kind of collaborative understanding of, how come this person's come at this point, thinking and feeling the way they do? What have been the influences as they were recently, the recent influences? What have been the triggers? What perhaps have been the structures, the ideas, the beliefs, the personalities that have been shaped by their environment, by the culture, by the life they've led up to now. So all of that, right? For any single individual, right, we're kind of a very complex set of influences. And if somebody's troubled, right, you can sort of there's signs of that, right? So if somebody wants to engage in that sort of exploration, I wonder what's going on for you, and I wonder where it's coming from, and what are the influences, and let's unpack them. But the important thing is that we do that with a purpose, right? And the purpose is better clinical outcomes, that people, in a way, have better diabetes control, right? Or they engage more with the sort of rehabilitation that they need to do after their surgery. Um, Perhaps they even prepare better for their surgery. Yeah. Perhaps they even manage to bring themselves to a point where they can tolerate certain tests or treatments, right? So, there's a variety of, there's an awful lot of treatments and processes in a hospital. And the goal of all of those, right, is to sort of restore people to the best possible health, to cure disease, to sort of manage disease and illness, to manage recovery, and so on and so forth. So that's absolutely what we're trying to do by doing this process of sort of exploration of the person, so that we understand, and how does your way of thinking affect what you're doing and how you're coping with illness. Yeah. And that is the kind of key difference from, perhaps what our sort of colleagues would be doing just a bit further down the road at Riverside, where they would be mental health psychologists, right? Their focus would be on mental health, difficulties per se, right? They'd be like, okay, so this is trauma, this is OCD, this is kind of bipolar depression. That's the pattern, right? That's the pattern. The patterns don't tell much about what's going on inside all the time, right? So they would do exactly this, but with a focus on that pattern. Whereas here, our focus is we use the same similar tools, similar procedures, yeah, similar expertise in a way, the psychological expertise, but embedded in the hospital's MDTs as much as we can. So whether it's a sort of diabetes, whether it's a sort of respiratory condition, whether it's a cardiac rehabilitation, whether it's a sort of you call it whatever it is. Our best sort of contribution there would be when our colleagues in their clinic, on their ward round, in the corridor, wherever, they kind of spot somebody who's like, okay, well, most people sort of manage to tolerate this unpleasantness, right? That is illness. And most people adjust, and most people sort of struggle. Of course, right? It's very human to struggle with illness and to be distressed and shocked and upset. But most people adapt. Yeah, most people, given the resources and the people around them, they manage to adapt, and they need support to do so, right? But that's the whole healthcare system does that, right? So doctors and nurses, a big bunch of what they do. I've got news for them, but a big bunch of what they do is psychological care, right? And they know that and they like that. And usually that's why they sign up to do this job, because they like the element of guiding a person through difficulty, right? So showing compassion, communicating, sort of anticipating the difficulties, guiding people. So there's an awful lot of psychological care the doctors, nurses, and everybody else expresses and provides. So, what do we do that's extra to that? Yeah. And the idea is that the extra to that is the bit where those things aren't enough, right? Where the physiotherapists are doing their best on a ward to engage somebody in getting up and getting going, but that person just withdrawing and, perhaps kind of looking a little bit sort of hurt or shocked or sort of bit. And the physiotherapist kind of picking up the fact, okay, this isn't how it usually goes. There's something that's kind of blocking this person, right? Let's bring our kind of psychology colleagues to explore that. See if the person's capable and willing to have a conversation. We can unpick what's happening in their minds at the point where they're in hospital and they're facing a really difficult process of getting back on their feet. What are the thoughts? What are the fears? What are the hopes? What are the strengths, that go there in the moment where they're trying to? What's holding them back? If we can understand that and just add that understanding, share that understanding with the physio, share that understanding with the ward nurses, share that understanding with the patient, say, right, okay, seems this is what's happening for you, right? And, then we try and find a sort of a path through that. Yeah. So how do we build up that confidence? How do we reduce that fear? How do you talk to yourself perhaps in a way that's more reassuring, more compassionate, perhaps that sort of puts away the fear and the uncertainty of illness and recovery. There always is fear and uncertainty, but for some people, it's just burst, right? It's sort of overwhelmed them and it's blocking them from doing the things they need to do to get stronger, right? And we sort of see, is there a path through that? So that's kind of a small example, really. So absolutely spot on there, Jonathan, in terms of identifying the tools of the trade. And what I'm adding is the kind of the focus, because sometimes it's easy to think of sort of health psychology as effectively a mental health service that just happens to sit in the hospital, and it's not really that. We do have our colleagues in liaison psychiatry, whose that is their scope, right? That they're very busy in A&E, they're very busy across the wards where people who happen to be in hospital, right? Also have severe mental illness or have kind of very, vulnerable mental states. That might start on a ward, or they might just bring that in, and they provide the the treatment, the care, the sort of collaborative working with the community mental health, follow-ups for those people, right? So their job is effectively the care of mental health in the acute hospital. And our job is the care of health, but by using psychological expertise. So we're kind of connected, very connected, very well connected, but we're also looking at a slightly different side of the coin. These things are really hard to delineate because human beings are not carved out in clearly delineated ways. I had a discussion with some sort of commissioners the other day about a service, and they said, what does this fall under, physical health or mental health? And I thought, okay, the dualists strike again. And of course, as people, they understand, right, that it's not that simple, but sometimes the structures don't quite help us to do that, right? So we try to do that bit where we bring in the expertise and the technologies of sort of psychological science and try to apply them to health, so that people have better diabetes control, better recovery, perhaps perhaps they have a chronic condition and their quality of life can be better managed if they can sort of encourage themselves in a certain way. Now, another example, let's say, along those lines, right, I was giving you before is, let's say, a dermatological condition. Let's say, and our colleagues in the dermatology clinic are particularly good at that. Let's say that they pick up that a particular dermatological condition can both be effectively aggravated substantially by stress and poor self-care, right? So in some ways, sort of psychological parameter can be causative to the difficulties, right? So there's something in that disease that is aggravated by, yeah. But also, even if the person is coping perfectly, it would still be doing all sorts of terrible things to their skin, which are a bit hard to live with. So the other element of that is, how does one face the world with this? Yeah. How do you go about doing things when you can't shake hands because your hands are constantly flooded with sweat for no reason, right? So hyperhidrosis, or you sort of have a particularly itchy and sort of terribly intense rashes. A lot of people can sort of find their way. Some people need extra help, and that's what we provide. Perhaps how do you build your confidence? How do you communicate that to other people? How do you get your family on board? How do you get your employers on board? How do you not sort of hide all the time, right? You are going to suffer from this in your life, clearly. How do you show yourself some compassion, some self-care? How do you work with your doctors on this? How do you not become despondent about this? As well as, okay, is there an element here of excessive, poorly managed stress in your life that might be over-tuning your body's response here and kind of causing some of this? Yeah, so that's a good example there, where psychological factors can be both a sort of a driver of the problem as well as a sort of okay, so even if it was medically optimized, you'd still have to live with. Other examples are perhaps where people have a difficulty coming up with a way of getting themselves to the hospital, right? At the best of times, it's not a bag of joy, right? Coming to the hospital, people do have a sense of help and sort of safety, right? But equally, they might have had particularly difficult experiences relating to healthcare, or perhaps with other aspects of their life, such that they make the whole institutional setting very difficult, right? So good example the other day is, there's somebody who our surgeons really wanted to see, because they really thought there was a sort of vascular problem that they could look at, and they could potentially help this person sort of walk better. To put it very bluntly, I'm sure I'm sort of losing a lot of detail here, but what I could read, what I could see is they really believe they could help this person, but this person just could not tolerate coming. Yeah. So the GP sort of quite astutely picked up that we might be able to do something about this. And indeed, when we reached out to this person, she was very willing, very aware of the fact that, for her, it was a long-standing problem in her mental health. And it wasn't particularly just the hospital where this was a difficulty, but she really wanted to improve her health. Yeah, she really recognized the problem. She wanted to come to hospital. So it was a case of, right, okay, so how are we going to help your health? Right, by trying to help you get here. Right? How do we do that? By trying to sort of manage that agoraphobia, that sort of element of absolute panic that sets in when you try to sort of set outside the door in the safety of your home. So we're kind of working with that at the moment, trying to see a little bit at the time, can we get this person sort of here, right? So here's an example where, perhaps it does kind of pinch a little, it does kind of eke a bit more on the mental health side of things, but really what we're trying to do is get this person to have better health. Like, if they do this, they also have other benefits in their life, yeah? But the objective is, can we get them to have these scans that the surgeon really wanted to have a look at? Can we get them to have that consultation? Yeah, can we get them? And sadly, sometimes we can't. The difficulties, the long-standing difficulties that people have in their lives are too entrenched, right? So we work with the respiratory team. Often they're like, this person's kind of habits, right? And that might include smoking and other things. Anxieties, sort of what they would or wouldn't accept from a sort of hospital are so long-standing. We would dearly like to give them X, Y, and Z, but it's just not right for them. They can't tolerate it. They can't accept it. And despite our best efforts, they still can't, right? So it's by no means a panacea, but that's the idea. It's like, can we try to bring in the psychological expertise to improve people's health, to back up what our colleagues do, And I suppose I'm talking, right? I mean, I'm sort of so good at talking. You wouldn't have thought that, right? And in doing that, I suppose the other sort of part of what we do is not just the kind of explicit staff support clinic. And I know you've talked to our colleague, Phil Pocock, who provides the specialty staff support, but also the kind of the softer, more immediate sort of staff support, which is, the human cost that accrues to the healthcare professionals trying to look after people who are in difficult circumstances, right? Perhaps the kind of the pain, the suffering, the rejection, the irrationality sometimes of people who are hurting. And the offering compassion that staff has to do comes at a cost on some level, right? You're not just doing the technical bit of the job, you have to put of yourself in it. And sometimes it's very rewarding and sometimes it's very draining, right? And when we come alongside our colleagues on a ward, on a clinic, like what's it been like for you looking after this person, right? And then they'd be able to say what their experience is and reflect on it and kind of acknowledge the element of, drain, perhaps, complexity, mixed feelings they have about this. I think that's really, really important. I think we're in a good position to do that. We like to do that. We want to do that when there's an opportunity, because we really fundamentally believe if as a hospital we're trying to look after people as holistically as possible within the limits of our parameters, the people looking after, that's where the energy is, right? That's where the kind of that's where the burden of that's gonna kind of. So it's everybody. So a good kind of corridor conversation for 5 minutes with sort of somebody who's caring for sort of somebody who's quite difficult circumstances can maybe make a little bit easier that day or that week, dealing with that person. So our contribution to staff really, not just as an explicit clinic, but as an everyday interaction. I rate that very highly. I hope that
Yeah,
gives some of
yes, no,
the
very much so. Yes, no, I was
dimensions of this.
yeah, no, I was going to say. I mean, obviously, it's equally important for staff just as much as patients to kind of for you to get an understanding of them and for them to I guess allow them to express themselves in a way that they couldn't maybe necessarily do with patients, and get a better understanding of of why they are seeing such and such, and I mean we've been going on a long time, but we'll try and wrap things up soon. The onus really is, I mean, obviously you can only do so much, but also it's on patients to kind of be receptive to your ideas as well, which I guess is quite a big challenge, or can be quite a big challenge for some people perhaps.
Yeah, absolutely. I mean, that's one of those things in a way that is perhaps a little bit not so obvious to sort of perhaps other people outside this. It is very obvious to a lot of healthcare professionals. Let's say the nurses on the medical round, the medication round. Here's your medication. I don't want it. People have ideas and sort of beliefs that might not align with what healthcare professionals think is the right thing to do, and that's where human nature and autonomy lies, right? Sometimes it's a bit not quite right. Other times it is right because we haven't understood the person very well, right? But it is absolutely central in psychology. There's nothing of any value to people unless there is a sort of a sense of them feeling safe and heard and listened to, before they might take anything at all on board. Yeah. So and so the offering really from the sort of the psychologist is, can we have a conversation about this, right? And if that's a no, then in lots of ways, right? People can withdraw or kind of cut off from that in lots of ways. So and I do feel really bad about that sometimes because we can see that people are suffering. We can see our colleagues are struggling to care for them, right? But such is the nature of the problem that we cannot directly, influence. So we're very keen to emphasize, reach out to us for advice about that, advice consultation. We've got this person and they're not accepting a referral, but, we do have these troubles in looking after them. Do you have any ideas of how we might approach it? I love to get requests like that, because those problems are going to exist, right? They're not going to go away because. So yes, absolutely, very much kind of based on collaboration with the person, and based on the sort of shared engagement. Without that, you can do very, very little.
And you find you see patients for do they keep coming back? Is it, I mean, do you have kind of what I'm trying to say is
Oh yeah,
how
well,
long
what
do
is the
patients spend with
what does
you?
it work? Yeah.
Do
So
they refer
that'll
back in 6 months, or for example,
Yeah,
or
so that'll vary an awful lot depending on the individual circumstances. So, for example, our colleague, our psychology colleague who looks after people as part of the ICU team, right? So they'll be part of the ICU team, contributing to the care of people while they're on the ward and for a couple of weeks after step down, right? So they're defined by that. Similarly, our colleagues who work in neurorehabilitation in Alderbourne and Daniels, they'll be looking after people while they're in neuro rehab. Whereas, for instance, our colleague who works in obstetrics and sort of gynecology and maternity, she might be looking after women in the pregnancy period, but also kind of for gynecological conditions that might take months or years of sort of treatment. So, the psychological input to that will be varied. It could be a one-off conversation, right? More frequently, it is a series of conversations where you first of all, as you said, sort of understand where the person's at, and then sort of just work together through different ways of adjusting and adapting and resolving perhaps some of the blocks or difficulties. Perhaps that might include, learning skills, so people would have heard a lot about so relaxation or sort of mindfulness skills, so there's techniques or procedures, right? And sort of similar things, or other times it might be simply very much about kind of reflecting and taking time to sort of take stock and kind of acknowledge emotions, such as sort of sadness and loss, and give them some time. So it's not invariably the case that you try to reduce or push away distress, because with illness, there is loss, there is sadness, right? There is, a part of your life that you would hope for, perhaps for short or long term, is altered. Yeah. And there are ways of kind of containing that sort of sadness and loss, but also has to be faced. Yeah. And so creating a safe environment where people can reflect, acknowledge that. Perhaps they might just be developing better self-regulation procedures and techniques. Yeah, so just organizing their approach to something. Sometimes it's about just absorbing, the information of what's happening, and that might take a bit, but at a long period. So it might be a series of contacts, but over quite a long period where things change in between for the person. Yeah. And that's one of the differences, really, but one of the significant differences with the approach that we bring to this versus perhaps the idea of a mental health treatment for X mental health problem, right? Which usually is a therapy of X, right? Whereas here, if the objective is health and illness, well, that takes many forms, right? So we have to be equally as flexible about, how do we do that? We certainly, not all of that is a case of we do 12 sessions, we do 12 appointments, we do 18 appointments, we do 4 appointments, and then it's fixed. It doesn't really entirely work like that. We're glad if it does. It's very good if it is possible to give people a good outlook and say, yeah, if we do these things, we have a really good confidence that it'll make things better for you. Yeah. And then we'll finish at that point, and you'll take this away, you'll take this learning away, and that should sort of help you for a while. But other times it's not as simple as that. So I suppose the main message is, that we really try to be very personalized in this approach, and kind of sort of put the kind of human individual factors before, before any sense of, sort of structure or package.
Sure. Okay. And a couple more things. I know we touched on earlier about you mentioned about if Hillingdon was a utopia.
Yes.
Kind of everything was kind of clearly set out and structured, and everyone knew what they were doing. What was it? Kind of the sort of psychology element was missing. Is that right? And
what would psychology look like?
Yeah, what would it look like for you then?
Yeah. I mean, it's a really interesting kind of situation, isn't it? Because in some way, wouldn't be great in a utopian sort of healthcare system. Wouldn't it be interesting if you fundamentally just didn't need at all to have psychology? Like, in some way, the objective, as with a lot of things, is that you don't be there, right? You're not needed. Why? Right? Because, the doctors and nurses that have to be there, right? Because, people will have illnesses and so on and so forth, right? But they have the time, the scope, right? The expertise, to do the medical, nursing, caring bits. And alongside that, do enough of that kind of guidance and support, so that actually for people, they feel entirely held by that. And that's what happens in a lot of times, right? People have psychological needs, and those needs are met by right? The doctors and nurses, the GP, the healthcare assistants, the physiotherapists, the speech and language therapists, the dietitian, the audiologists, the people who do the scans, the people who take the bloods, and such a complicated system. The LAS, right? Huge amounts of sort of psychological skill. So my ideal system would be like everybody's got the time, the expertise, the training. Okay, so maybe some people are a bit more, their lives are a bit more complex. So you might need a few sort of psychologists. Okay, fine. But ideally, you need the fewest possible. And the idea being also that you've designed systems. So first of all is you have the people, right? The people have the skills, the people have the time. And then you have also the systems, right? Now we have to do certain things as a healthcare system that aren't really ideal for psychological adjustment, right? We have to do all sorts of things to keep afloat, that aren't really conducive to what human beings really need. Yeah, human beings really need to feel attached, right? They need to feel safe in relation to. Now, arguably, a hospital is not a great place to be attached, but a doctor or nurse are like a safety, right? There's sort of makes us feel safe as human beings that somebody will look after me if I'm unwell. But what do we do? Oh my God, try to book an appointment, huh? So what we'd also have is a system that kind of understands that human beings, when they're suffering and they're vulnerable, they're not, they kind of need a sense of, okay, yeah, come, we'll look after you, as opposed to, ooh, I'm not really sure you filled in this form correctly. Yeah, well, I don't know, maybe you could go somewhere else. Yeah, it's like, yeah, come. Yeah, just come in, have a cup of tea. We'll see to it. Yeah. So I think we do, and that's a massive kind of oversimplification of the whole thing that that kind of creates doors and barriers and difficulties and procedures and all sorts of things like that. Here's your appointment. Oh, we cancelled your appointment. When's your next appointment? No, I don't have one for 6 months. I mean, maybe strictly speaking, medically, that's not a terrible thing. Maybe medically, okay, that's as much as is needed. But on a human level, people feel abandoned, right? And, we were talking before about, what I would like to see in a way, or what I've seen over the last kind of, decade is I think there was a period, a few years back where we're perhaps a little bit more, more in a good place thinking about kind of patient experience. And I think now, performance, right, waiting lists and sort of, the tight state of the estate of finances, and I just really, really wouldn't want to be in a position having, carrying the responsibility for that, but just to hugely understand the limitations there and the challenges there. But the result is, I think that, we might, I hope that we might in the future be able to have enough headspace to return to the idea of patient experience. Like, okay, how do we communicate to people, reassure them, bring them in, rather than just be brutally efficient in our healthcare. And in fact, if it's anything, it's that, you hear more from people, what a toll that takes. Yeah. That, and it doesn't take an awful lot for that to be destabilizing psychologically, right? When people can't quite get enough time, enough, communication time, enough sort of support, and so on and so forth, in those processes, right? So they end up kind of being muddled and confused and angry and frustrated, and that boils over, and they come to us, and we hear the story of, I would have been okay if these things had worked. Yeah. And of course, there are people where everything works well enough and still they struggle, and that's kind of human nature, right? But I think if we could possibly fix the iatrogenic, for the fancy term, if we could fix the iatrogenic, if we could be proactive, if we could pick up distress and difficulties early before they boil over, if we could give staff the right space and time and mission, one of my biggest sort of concerns often is that um, elements of psychological care are often extracted from healthcare professionals' roles, right? Um, to other kind of healthcare professionals on the basis of efficiency and cost, right? So a great example is cancer nurse specialists. I did that for 15, 16 years. It's sort of Charing Cross and Imperial, as like the rest of the country, had to contend with the fact that actually you could never have enough clinical nurse specialists because treatments were more complicated. People's lives are more complicated. They need a lot more guidance, support, and a lot more. So hospitals had a lot more kind of reporting demands and lots more procedures. So the guidance and the support that comes from clinical nurse specialists. So they said, right, okay, we need a bit more help. So I said, right, okay, what we're going to do is bring in some, cancer support assistants, and they're going to do the psychological bits of support. And you can go, hang on, that's the trickiest bit. And we're extracting that from a kind of professional, holistic care, not because, cancer support workers are not brilliant people with all the will in the world, but they're not CNSs of 10 years experience, right? So we're kind of, sometimes we end up extracting psychological distress, not dealing with it up front, yeah, and extracting it a bit procedurally and pushing it somewhere else because we're trying to get this bit to be a bit more efficient. It's like, what can we? Oh, okay, we can't not do surgery. Okay, we have to do surgery. What else do we have to do? Oh, we have to do chemotherapy. Yeah, we have to do that. Shit, what can we? Yes, psychological care. So maybe we can. I'm sure it doesn't, it's not exactly how that meeting went, but it kind of sort of feels like that. And I think there was a bit where we were going kind of a bit more the other direction, going, right, if really early in the pathway we did actual sort of holistic assessment and care planning, and we gave professionals more skills and time to do that, maybe we could sort of get rid of the psychologists. I wouldn't mind.
Certainly, it's fascinating to think, and just finally, then going forward, then I mean, you've touched on what it could look like one day in the future. Maybe it's more in the short term. What things would you like to see? What sort of structures and procedures would you like to see in place, which would make your job easier and make life easier perhaps for patients coming in? We've hinted that in maybe more the past decade or so has been a greater awareness of psychology and what psychologists do, and awareness of mental health and with the promotion of social media, etc. But in 10 years' time, how much would your job have changed, would you say, or if at all?
Yeah, I mean, in some way, I think the future exists in our just a bit down the corridor, in our colleagues in pediatric psychology, right? So I look after adult psychology. My colleague Leah looks after pediatric psychology. Not quite as many of them, but I think they're kind of a really excellent example. Shout outs to them folks if they're hearing, because they're effectively sort of fully embedded, fully embraced. They think of procedures together, right? So they're kind of thinking about X clinic, and that kind of psychological element of families and children is sort of built in. And sort of pediatrics is a bit like that. The culture, the values, the kind of outlook is a bit like that. So in some way, it would be really nice if we move towards that idea of thinking, when a clinic or a program or a pathway is kind of reviewing or checking or evaluating or redesigning, we're kind of sitting there having that discussion of how do we start to look after people, at the point of referral or intake, or, they come through the front door, right? What do the staff need to look after them? What knowledge, what procedures? Yeah. How do we sit together and bring the expertise in early? How do we design the pathway? How do we take the right people through to the more specialist, but actually how do we support the rest of the staff so that it's really more embedded? So yeah, ideally over the next 5 years, I might be hoping to do one or two bits of work with particular, areas or clinic that say, right, okay, we have a chance here. We're remodeling X or Y and Z. How can we build in the psychological care early? Yeah, rather than extracting it after trouble and sending it that way. Yeah, how can we bring that expertise, put it in upfront, improve the care for everybody, and also pick out the few people who do need that extra care? But everybody gets that slightly more enhanced and sort of psychologically minded care. So I'm sort of hopeful about that happening in a few years. Within the next few years, we can do a little bit more of that. That would be really nice.
Great. Well, I think that's a nice note to end on, and something
Yes.
we can certainly keep an eye on. Great. That's lovely. Thank you very much indeed, Alex, for coming on the podcast. I hope you've enjoyed taking part. It's been really fascinating discussion, and hopefully a very kind of eye-opening one for people as well. So they know a lot more about what you do and what your profession does, and the service that you provide to patients here at the trust. We'll be back with another podcast very soon, so keep an eye out for that on Buzzsprouts or wherever you get your podcasts. And if you are listening and want to get involved in a future podcast, then just email thh-tr.communications@nhs.net. Thank you very much indeed for listening today. Thanks once again, Alex, for your time. And until next time, goodbye.
Thank you.